Välkomna till Stora Aktiedagen här i Stockholm den 29 november 2022. Jag kommer nu att byta språk till engelska. I will change language since we have the pleasure of welcoming Ellen Donnelly, CEO of Abliva, and she will give us a presentation. And afterwards, there will be an opportunity for me, but as well as for you viewers, one way or the other, to ask her one or two or maybe even three questions. And how you do that will be shown up on your screen. Ellen Donnelly, welcome. It's a pleasure to have you here. The floor is yours.
Thank you. I'm just going to start with a bit of a preview. Imagine you're a new patient. You give birth to this adorable baby boy and have enjoyed watching him grow up and develop. Your son develops a common cold. Not a big deal, says your pediatrician, but then he starts to rapidly decline, regressing in his milestones, losing his appetite, and now he started having seizures. You consult your pediatrician and she refers you to a specialist center. A genetic test confirms your son has Lee syndrome. Given the severity of the symptoms, he's given 2 years to live. And there are no treatments you can give him to lengthen his life and nothing that will relieve his suffering. To provide a bit of hope, the physician mentions that recent advancements in mitochondrial biology has enabled the development of new medicines. Abliva is the company working to develop these medicines for rare diseases called primary mitochondrial diseases. I'm Ellen, the CEO of this company, Abliva. Given the rarity of these conditions and the different backgrounds in this audience, I'm going to start today with a bit of biology. So as you know, our bodies are made up of cells, a lot of them, 40 trillion cells. These are formed to make tissues, organs, and they combine to make the systems in our body. These cell types are listed here. But what I'm sure you haven't considered is how those cells get their energy. Those cells, each one of them, except for your red blood cells, are powered by organelles called mitochondria. And that's what we're going to be talking about today. They're in every single cell in your body. So what are these cells, these organelles doing? They're creating the power that your cell needs to do their job. So these are the organelles that create something called ATP or energy. The number of mitochondria in each cell can be over 100,000. And there are more mitochondria in the cells that need more energy. The interesting thing about the mitochondria is they actually have their own source of DNA. So we often talk, you'll know about these genetic gene therapy companies. We often talk about nuclear DNA. But this is a different type of DNA. It's called mitochondrial DNA. You get it from your mom, and it doesn't have the same proofreading that other DNA has. So it often has mutations. And that's where primary mitochondrial diseases come in. Colleagues at Abliva have been studying dysfunctional mitochondria for over 20 years. And finally, the biology has come to a place where we can start targeting those mitochondria that aren't working right. Here on the left, you can see Eskil Elmer. He's our CSO, founder of the company. He runs our research organization, which you can see down here at Lund University. That's our lab. Magnus Hansen, over on the right, runs our development organization at Medicon Village. These two met over 20 years ago and have been working on mitochondrial dysfunction almost since then. They're supported by a talented team of colleagues that are based in Medicon Village, and I'm based out of the US in Boston. So our company is focused on targeting the powerhouse of the cells to improve the lives of mitochondrial disease patients. So what are these diseases? We just told you about that little boy who has Lee syndrome. He has a very severe case of this disease. And as we mentioned, most of these children die quite early. These are all rare diseases. They affect about 1 in 5,000 individuals. They're debilitating and disabling disorders. Since they impact the organs with the most mitochondria, we often see impact in the brain, in the muscles. So the patients often will have a hard time moving. They may have tremendous fatigue, not be able to get up, take a shower, and go to work. Life expectancy depends on how severe your disease is, but we have the babies that die very early, and then some people can live, 20, 35 years of age. There are no approved therapies. These patients get this diagnosis, and they're basically told to just manage their disease as they're able. So there are a number of reasons why this is an attractive place to work right now. And when I mention rare diseases, people often say, oh, well, that's got to be tricky. You know, these patients aren't very common. It is tricky, but there are some things that have just happened to really make it easier for us to develop disease, therapeutics in rare diseases. The first is that this rare disease indication brings substantial benefits. We get regulatory guidance, so we can meet with the regulators frequently early on in the project to get their thoughts on what we need to get this drug approved. We can move to market quite quickly. An example is our program, which I'm going to talk to you about, KL1333, has moved from phase 1 now into a phase 2 study, registrational in quality. So if that study that we're about to start works, we could be on the market as soon as 2026. That's pretty fast. The average drug takes 12 to 15 years to get to market. We could take 6. Small studies. We only have a handful of patients available, so we study a handful of patients. So the study I'll tell you about is about 120 to 180 patients. This compares to oncology or cardiovascular studies with over thousands of patients. We often have regulatory tools that we can use. ODD designation or orphan drug designation gets us a layer of protection once we reach the market, so nobody can come out and compete with us with a similar mechanism of action. It also allows us to get pricing freedoms. Governments and regulators realized that nobody was going to develop drugs if they couldn't price them appropriately. It's just too expensive to develop drugs for rare diseases. And so we are able to premium price these molecules. So all of these regulatory kind of opportunities here really de-risk the program, streamline our development, and give us the blockbuster sales potential. Another thing that's happened that makes this kind of the time to develop drugs in this area is these patients are finally tracked. They are sent to centers of excellence in each country. There are 2 or 3 in each state, a similar number, but their pediatrician or their physician will recognize that they may have mitochondrial disease and send them to a specialist who then diagnoses them, helps them manage their disease, and helps us run our clinical studies. They often do important research as well on the disease, and that always helps us. So these specialist centers have just started to emerge. This is going to help us both with patient diagnosis, with disease management, and with patient identification. It also gives us an important tool because we have a goal to commercialize this medicine if this study is positive, and we can do that because of these specialist centers. We don't need a large sales force. And we know where the patients are. They're sitting at these centers. Another thing that's helpful in this area right now is that there really is a fairly sparse competitive landscape. I show you some of the competitors in the peripheral space. This is it. Abliva, our lead compound, is really well positioned with the other competitors, which are listed here. You can see we're all at the same stage of development, and we're all reading out in the next 2 years. These are peripheral therapies. What that means is these are for your body. They don't get into your brain. The other therapies that are available are being developed are CNS therapies. So these are therapies that do get into your brain. Again, you can see the competitive landscape here. We're a bit earlier than those, but still have the opportunity with both of our drugs to be combined with any of these. So this is really an open game right now. We're all trying to develop medicines for these patients. And frankly, anybody that's successful will only bring success to the other companies because it will open up the market. Patients will come out. Suddenly they have a therapy. And so I think that number will increase quite significantly. So what I've just talked about is why mitochondrial disease and why now. I think that this is a really important time for our company as well as the other companies in this space. We started to understand the mitochondria and how to target them. We had these tools available that help us get to the market with less risk and faster. The patient groups have started to organize. These have been really important in the development of our company and our protocol, and just a tremendous resource. And then these centers of excellence. So as I mentioned, really decrease risk, decrease time to market, and decrease cost to the market give us a huge opportunity here. On this slide, I show you the opportunity that we've estimated for the lead compound, which is KL1333. You can see here peak sales of about $1 billion US or 100 billion Swedish. That is a conservative estimate. That's assuming we have the number of patients we have now. We identify about 50% of them. We treat about 50% of them. And then we price it fairly reasonably. When we talk to payers, as we talk to payers and regulators frequently, they say that this could be about a $300,000 a year drug. We've priced it here at $160,000 in the US and then about half that in Europe. It could be higher. And if it gets priced higher, you can see that that number will be pretty significant. So here's the portfolio. I'm going to talk about each of these programs separately, so I'm not going to go into much detail. The one thing I want you to remember is we're about to start a major study, the KL1333 study, which I'll talk to you a bit today about. And then we have another program in earlier development ready for phase 1. So these are the two programs. KL1333 is about to start this global, potentially registrationable study. It's a first-in-class drug, so that means it's the first type of its kind. It's going to modulate NAD plus NADH, and it's going to target adults with multisystemic disease. That means the disease is throughout their body. They're not just impacted in one of their systems. They don't just have cardiac issues or respiratory issues. They really feel this disease throughout their body. NV354, our second program, is very different. It's a first-in-class energy replacement. It's a prodrug of succinate. This gets into the brain, and because of that, we'll target pediatric Lee syndrome first. It has a very big cognitive component, but it's also beneficial likely in other primary mitochondrial diseases, which we'll talk about. So big opportunity again with this program as well. So KL1333. When you're developing drugs, as you all know, you do a preclinical package. And in this preclinical package, you talk about, you understand the drug, the dynamics, what the drug does in the preclinical setting. So here you can see some data in the background, just from patient cells, from animals, from other cells, where we tested the effects of KL1333 in many conditions. And we found simply that KL1333 improved mitochondrial function, important, it improved muscle function, and it impacted relevant biomarkers. We also have done extensive safety testing on the molecule, very important. And we've dosed over 110 healthy volunteers and patients and found that we have confidence in our safety profile. So all of that preclinical package looked really nice. But the next question is really, what does this look like in patients? And so we did a study called a phase 1b study with patients and treated them with KL1333. Now, in this study, we ran the usual group of healthy volunteers. You might think of phase 1 studies as healthy volunteer studies, where we're looking at the pharmacokinetics and the pharmacodynamics of the drug. But in this study, we added a cohort of PMD patients, patients suffering from our disease of interest. And we looked at 3 clinical endpoints. So we gave them the lowest dose of drug because this was the first time we'd given it to patients. And we dosed them for 10 days and only 10 days. And so we said, over those 10 days, I wonder if this drug shows us any beneficial effects in these patients. And surprisingly, because it was only 10 days and a low dose of drug, we did see great benefits. So here you can see the 3 clinical endpoints. The first one is the NeuroQol fatigue form. So this is a form that the patient fills out every day and says, over the past 7 days, how often have you had a problem walking or had issues with your energy? And it's a very specific form that's used across many different indications. And you can see here that the placebo group in gray, these are the patients that got a fake pill. It was a placebo pill. They did poorly. And the patients that were treated with KL1333, the 6 that are shown here in black, did quite well. There's a nice difference between those groups, suggesting that there was an effect from KL1333 on this endpoint. But we wanted to look at more. So the second endpoint we looked at is a daily fatigue impact score. Again, it's a scale where the patients answer questions, but they're asked over the past 24 hours. Different questions, a different time frame. Again, you can see good difference between placebo and the drug. And then the third test we did was measuring something completely different. This was measuring their muscle weakness or myopathy. In this test, the patient stands up and sits down as many times as they can within 30 seconds. Again, you can see a nice difference between the 2 groups. So this was pretty compelling to us. First off, we were successful on all 3 of the 3 endpoints. But also, if you look across different disease areas, this appears to be a clinically meaningful difference. What does that mean? That means that the patient could and should feel a difference from our drug versus being on placebo. That's a pretty substantial thing to say, right? I took this drug for 10 days and I felt better. So those were very helpful. Now, we also looked at the correlation between drug and efficacy, or exposure and efficacy. And what you can see here is, I won't spend time going through it, but it appears that the patients that had more drug in their blood did better. And you can see that on the left-hand figure. You can see the 3 dots over to the right had more drug in their bodies. And then in the figure on the right, you can see the KL1333, the black bar. Those are the same patients. So you can see they did dramatically better than the patients in the middle who had less drug in their body. And then on the left of that figure, you can also see the placebo patients who did the worst. So this is really important in drug development because we've shown an exposure effect relationship. And that really suggests to us that the drug is what's driving this response. So great to see that. Okay, so this was the phase 1b study. So you may ask me, what are we doing next? So we had that data and we saw this data coming out of these fatigue short forms. And the problem with these short forms, you may have heard about fatigue in other studies, is that they're not specific to the disease. So when we were meeting with the regulators, with the FDA, we spoke to them about creating a fatigue form that was specific to primary mitochondrial disease. We did that over a process of 2 years with patient studies and the help of UMDF and Sprout, which were instrumental in getting this work done. And we created a PMD specific short form. And that's a really big deal because now we have a specific form to measure our patients' fatigue in our upcoming study. So what does this look like? I told you we're about ready to start a study. Yes, we are. That Falcon study is the name of the study. It should start in December. We have some highlights. It's adult patients with systemic mitochondrial disease. We're going to start 40 patients, and they're going to go to an interim analysis, which should happen at the end of 2023 or early 2024. In the full total study, we'll have 120 to 180 patients. This is a very patient-friendly study. We did that because these patients are sick. They don't want to come into the hospital. So basically, they'll take our medicine home with them. They'll do our daily assessments. They'll come into the clinic, I think 5 times during the study. But they'll take that medication twice a day for 12 months. And what we're looking at is the 2 endpoints that we know bother the patients the most. We're looking at fatigue with our custom short form, and we're looking at muscle weakness. That study should read out in 2025, and we expect if it's positive, we could have marketing approval as early as 2026. That means revenue as early as 2026 with this program. The second program I'll just highlight briefly. As I mentioned, this is going to target that little boy that we learned about first. We have some great data on that. Again, we did our preclinical data package. We took it to the regulators and discussed it with them, and they said it was ready to go into phase 1. So this at the moment is just preparing for a phase 1 study. We have optimized the drug properties. You can see some of the data on this slide, both the brain distribution, which I've shown on the right, as well as the fact that the drug impacts mitochondrial function in patients from these cells, in Lee patient cells. We also have some data out of Barcelona showing some more effects. It decreased inflammation in the brain, it delayed clinical and motor signs, and it improved weight gain in these mice. So nice data on this program. One of the things we've done most recently is we raised a large round of money in June, and that was one of the top financings in Europe in Q2. So pretty proud of that, and thank you all, those who contributed. The highlights of that raise were that it will take this KL1333 program to that key inflection point, that interim analysis. It allows us to get NV354 ready for the clinic, and it provided us with a 2-year runway. So really happy to have that cash in the bank as the market continues to be a bit soft. I just wanted to highlight 2 important groups that support this program. We couldn't be here without them. The first on the left is our board of directors. This board of directors comes to the company with a lot of experience, both in Sweden and abroad, and has been a fantastic resource as we move these programs towards the clinic. The scientific advisory board as well is kind of an extended member of our team. They are all critical. They're our sounding board when we're looking to design protocols. They're our experts. They treat these patients every day. And so when we were talking about our primary endpoints, we talked to them and we said, what really bothers these patients? From your perspective as a physician, what would you like to see addressed? And that's how we ended up with fatigue and myopathy. So huge shout out to these individuals. Grania and Rob at the bottom were instrumental. They ran our phase 1b study and got us that data I just showed you. They're both based in the UK. So here you can see our team, both the board and the team at Abliva. Our focus is really to become a leader in this space. I've told you a lot about why the time is right to do that, and I think we're well positioned with a portfolio of exciting programs, both first in class in an area where there isn't much competition. So we have a fully experienced team that's been working in development for a long time. We've opened a Boston subsidiary and have our office in Lund. We have these R&D capabilities, and we're ready to go. So looking forward to getting that study started next month so we can tell the market about that success. So thank you all for your time today. I appreciate it and look forward to your questions.
Thank you. Thank you very much, Ellen. Pleasure to hear the presentation and gave us a much better understanding of the company and definitely where you're heading. The way I understood it is that if you by 2026 have a finished product ready to go to the market, then my question is, how is that going to happen? Are you going to set up a partnership, or are you going to do it all by yourself in order to capitalize as much as possible? Or what's the idea?
It's a great question. Right now, our intention is that we would do it ourselves in the US and partner in Europe. This is primarily the way it's done, just because the European regulatory environment is so complicated. Each country has its own guidelines, and you need to set up basically a country office in each country to deal with the financial, regulatory, and ethical aspects. So I think when you look at the data, about 55% of biotech companies actually partner in Europe and do it themselves, of the companies that do it themselves in the US. I think Aktiedagen is a great example, a great Swedish company that has done exactly that. So that's our plan right now. If partners came and talked to us, we always keep an open mind. But the nice thing about rare diseases is that you can do it alone. Our estimate in the US is that it takes about 20 to 30 sales reps. And because these patients all sit in these centers of excellence or are all managed by these centers of excellence, it makes it easier because we don't have to have many sales reps to detail this drug. So the plan right now is to do it alone in the US and to partner in Europe.
Okay. We have a question here from someone in the audience. I don't know where, but it says, are mitochondrial diseases on the uprise, or does it follow the general increase of the world population?
Really good question. And we've tried to look into that. They're so rare that it's really unclear right now. We believe it's following the same increase that we're seeing in the world population. As I mentioned, though, you get it from your mom. So often what we see is infected families or affected families. So a couple of the children may also have mitochondrial disease, as will the mother. Prevalence is a bit different throughout countries, but nothing compared to the difference in prevalence you see in other countries. So I think it's probably pretty stable. The problem is it's hard to measure. And without therapies for these patients, I think many of them are not getting diagnosed.
Okay. Another question reads like this. If your competitors also succeed within their studies,
yep,
would you still retrieve your orphan drug status?
Yeah, yes, absolutely. So orphan drug status stays with you. We don't have any competitors with our mechanism. So we will still have the orphan drug status if we get approved. If we have one competitor that looks like they may get data before we do, that's Reneo. They have a PPAR delta modulator, different mechanism of action. That actually, if you look historically, opens up markets. So it actually is not a bad thing for Abliva. It's a good thing for Abliva. We're complementary to that mechanism. We could be used in conjunction with them. And there are enough patients for us all to treat. In that billion-dollar market estimate I gave you, I assume they come to market first. So I assume I only take 40% of that share. It's still $1 billion. This is a high unmet need area, and there is much room for many of us to play. which is a nice place to be.
But it's like you said earlier in your presentation, if one succeeds, it will help and assist the other ones to get an acceptance and to grow the market.
Absolutely. People need to know we can treat these patients. Mitochondria, it's kind of like treating the brain and Alzheimer's disease. You know, there's this perception out there that this is tricky. And so anything we can do to change that perception, publish our scientific data, et cetera, show people that we can treat that, that's going to be important in growing this market.
Where do you conduct your studies? And how will you finance them for the coming years? I think you answered the second part of the question when you said that the rights issue that you just carried out will take you for another 2 years ahead. Is that correct understood?
Yep, that's correct. The studies are run, the 1B study was run in the UK, and I mentioned those sites. The global study that we're starting right now is going to be run in the US and Europe. And so that should be published on clinicaltrials.org very soon, so you can see all the details on that study. And then we are financed now through the interim analysis, and so in a good position there.
Okay. What are the biggest challenges, the way you look upon it, that you have ahead of you for the coming years? You've probably mentioned a few of them, but please, if you've done so, could you repeat them so we could carry them with us once we start following the company even closer, because you're in a very interesting position now and lots of things will happen.
Absolutely. I think challenges, as any public company has as you continue a long study, is to make sure that there's news flow. And so we're constantly talking about what we can do to keep you all informed and be transparent in our communication. So that's one of our key things, because as you can imagine, once we start this study and start treating patients, we don't look at data. So there's very little we can talk about as far as the study until we have the actual data. So that's going to be really important to us. I think recruitment could pose a challenge. We don't know how quickly these patients are going to come into the study. Now, we have reason to believe from other indications and other spaces and from our competitors that these patients are pretty willing to do studies and are anxious to get a drug. But that's always an unknown question in clinical development, how fast you're going to be able to recruit these patients into the study. So I think that's one challenge. And then I think another thing is we're a small team, so we need to grow and to support these programs, and NV354 is going to be an important program as we look to develop the company. So looking forward to finding a path forward for that asset as well.
Okay, one last question, a bit more of a personal one. How come you yourself are based in Boston while running a Swedish company?
Oh, thank you for that question. So the way I came to this is I lived in Stockholm from 2016 to 2019. We moved for my husband's job. And so we were in there. At that time, I was the CEO of another rare disease company called Modus Therapeutics. It was focused in sickle cell disease. So I lived in Sweden. My Swedish was okay then. It's absolutely awful now. After living in Sweden, we moved to London, and then we just moved back to Boston and used this as an opportunity to set up the US subsidiary. We do have a lot of activities happening in the US with the global study, as you can imagine. So it's important to have somebody here. I can go visit the sites with my clinical team, and we can have, we have easier access to vendors. And then I come to Lund, once a month. So I'm usually there for a week a month, and often take the opportunity to meet with our shareholders when I'm in the town.
Okay. Thank you for those answers, and thanks for the presentation. It will be interesting to follow you into the coming future here. Thanks once again.
Thank you for your time.
Thank you.
Thanks, everyone.
Applause.
Bye.